Hi everyone, good morning. Welcome to the Epi competition. Before we get started with that, we wanted to kick things off by talking a little bit about the SHEA Research Network as everyone kind of filters in and gets their breakfast. So my name is Katie Shodis and I'm one of the co-chairs of the SHEA Research Network, and I'm here with Sarah Keller to start today's discussion. We have no financial disclosures or conflicts of interest. So to start, what is the SHEA Research Network? So we're a consortium of healthcare facilities, both in the United States as well as internationally. And the goal of the SHEA Research Network is to promote research collaboration to answer kind of timely and relevant questions in healthcare epidemiology and antimicrobial stewardship. Each member institution designates a principal investigator, and our studies and surveys are answered at the center level, so each member is actually representing a single institution or center. The SHEA Research Network is supported generously by SHEA and the SHEA Foundation, the SHEA Research Committee, but really most importantly, the people who volunteer to be members of the SHEA Research Network at these institutions. In terms of our leadership team, I've already introduced myself and Sarah, who serve as the co-chairs. We're also supported by two fantastic staff from SHEA, Nkechi Emetuche, as well as Valerie Deloney. And as Sarah will tell you a little bit about later in the presentation, we're actually seeking a third co-chair for the SRN leadership team. In terms of the demographics for this year, we are at 100 participating facilities, the majority of which are located in the United States. There's 36 United States represented, as well as the District of Columbia. And you can see from the map that we have a pretty wide geographic representation, which we're very proud about for this year. We also have 16 international facilities representing 9 non-US countries. Most of the facilities in the SRN are acute care facilities, and we do have both adult and pediatric facilities represented. So what's required to be an SRN site? So really, most importantly, is a committed principal investigator who's willing to participate in surveys and SRN research projects. As I mentioned before, because our surveys and projects are generally performed at the center level, there's really only allowed to be one principal investigator per site, but that person can always designate someone else to answer the survey, participate in the project as appropriate. Any type of healthcare facility can join the SRN, but some projects or surveys may be more relevant to one facility type or the other, so not everybody may be able to participate in all of the studies. And of course, there's no fee to be a member of the SRN. In terms of the type of work that's put forth by the SRN, by far and away, survey designs are the most common study types that are performed within the SRN, including surveys related to stewardship or infection prevention and control practices, individual perceptions and attitudes about a certain topic, and then some educational or educational programming information can be provided by these surveys as well. Sometimes we use surveys to inform guidelines or other SHEA publications, and a good example of that is the recently developed, or the ongoing research agenda, which we're currently working on in collaboration with the research committee. And we also use the SHEA Research Network to recruit for larger studies like clinical trials or larger observational studies, and those projects often come with funding through those investigators. Overall, we have a publication rate of about 75% of studies that are put through the network, so we're very happy that this work is getting out there and hopefully helping people take better care of patients. I'm now going to turn it over to Sarah Keller, who's going to talk a little bit more specifically about some of the studies that have been done within the SRN. Thanks.
Hello, everyone, and I promise we won't keep you too much longer because I know we are just here before the main event, which I'm very excited about. But just a few things that have come out very frequently in journals such as our own ITGE and ASHE in preparation for the hospital-onset bloodstream infection / hospital-onset bacteremia / healthcare-onset bacteremia. A survey was done at the SRN looking at just opinions about this as a potential HAI metric. So a helpful resource to look at. And I believe this article is actually referenced yesterday. It's been a long couple of days in one of the talks, looking at practices around post-procedural antimicrobial use. That was very helpful. We've also had, I see Dr. Clay's here right now, but another study looking at diagnostic and stewardship approaches taken with molecular respiratory testing that kind of got at stewardship. So as you can see, we've had HAIs and stewardship as so far. And then looking at prevention practices for non-ventilator hospital-acquired pneumonia was another article that came out just within the past year in Itchy. And then this other very interesting article that kind of touched on a couple of different things, looking at air change rate practices in operating rooms, and a little bit around climate change in the setting of COVID and practices associated with that. So as you can see, so many of the SHEA and Itchy articles actually have some SRN involvement. And there are some active projects that are either, as you can see here, that are kind of getting near being written up or have been recently published. But we did want to provide with this QR code if anyone is interested, looking at all of the recent SRN studies, and really there have been quite a few. Just wanted to really quickly mention, for those of you who are interested in submitting a study, there is an online application. It gets reviewed by the SRN leadership for scientific merit and in keeping with priorities of SHEA, often for surveys, having an additional couple of sets of eyes, looking at whether the questions make sense, and things like that. It then gets piloted beta tested by some members. And again, typically this is recruitment for other studies, but most frequently these end up being surveys. And we would always love additional members, member facilities. So if your hospital or your facility is not a member, there is this QR code as well to take you to the site to apply. And again, as Katie was saying, the registration is on the hospital level, not the PI level. And there's one PI at each hospital. However, if the question is, if you do hospital epi and the survey is about stewardship, you can pass it on to your stewardship colleague, vice versa. And so that is absolutely fine. And as Katie had alluded to, we are interested in looking at a co-chair. We thought that it would be helpful to have some additional expertise in infection prevention and control. So our preference would be someone with expertise in infection prevention and control, such as operational leadership, or this is where their research focus is. We have monthly leadership meetings. We frequently review proposals and provide feedback. And then we also strategize ways to promote the SRN and related studies. So if you're interested, you can reach out to us. And although Nkichi is not here, I don't see her right now, her as well. And I'm looking at Val, who's also shaking her head, so that is fine to reach out to her as well. All right. So with that being said, we're going to turn things over to what you guys are all here for, the competition.
Good morning, everybody. I'm Tom Talbot. I'm the president-elect of SHEA. Thank you all for coming this morning. Hopefully you got some good breakfast and you're here for the main event. I kind of feel like Oprah Winfrey. I'm stealing that from Monica, but you get a grant. So we're excited for the Epi competition, a $20,000 research award through the SHEA Foundation. And we'll start with, as our panelists get up as well, we're going to show videos of the three projects. And then after that, we will have each of the competitors come up and answer some questions from our panelists. If we have time at the end, there will be some chance for audience questions. It just depends on how we have time. So we'll go ahead and start the video, and then we'll get the question and answer process started.
Welcome. Today, I will introduce you to the project titled Improving Patient Safety Through an Enhanced Understanding of Current Practices of ARO Screening in Healthcare Facilities. I am Jenine Leal, Research Scientist for Infection Prevention and Control at Alberta Health Services and an Assistant Professor at the University of Calgary in Canada. Increasing antibiotic resistance is a global problem. Antimicrobial resistance contributes to significant mortality across the globe. New resistance mechanisms continue to emerge, threatening the ability of acute care hospitals to guarantee patient safety. Lengthier hospital stays, longer courses of treatment, and other expenses attributable to antimicrobial resistance is estimated to cost the US more than $4.6 billion annually. By detecting individuals colonized with AROs through hospital admission screening, enhanced precautions can be implemented to interrupt transmission. With the implementation of electronic medical record systems across Canada and the inclusion of an electronic ARO screening tool as a clinical decision support tool, there is opportunity to conduct a population-based evaluation of the ARO screening protocol and to identify gaps in practices across different acute care facilities. Although routine screening may seem straightforward from an IPC perspective, it may be considered a complex intervention given the need to embed it into the everyday work of healthcare providers. Therefore, it is important to understand individual and group factors which may influence the implementation and ultimately the effectiveness of ARO admission screening tools in EMRs. The goal of this work is to improve patient safety by reducing the transmission of AROs in acute care facilities through the efficient and accurate identification of patients with AROs. To achieve this, our project is broken down into 3 objectives. Objective 1 is to evaluate retrospectively the implementation of the electronic ARO screening tool in EMRs. We will conduct a quantitative retrospective cohort study and an ecological study using secondary data sources to evaluate the adherence, accuracy, and effectiveness of the ARO screening tool in EMRs from approximately 50 hospitals in Alberta and Ontario, Canada. Data from Objective 1 will inform Objective 2, which is to identify barriers and enablers to the implementation of the electronic ARO screening tool. We will conduct qualitative focus groups with clinical staff to understand the determinants influencing the implementation of the ARO screening tool mapped to the Theoretical Domains Framework, or TDF. A matrix that links each TDF domain to potential behavior change techniques will be generated using the behavior change wheel. Finally, our third objective will be to prioritize the behavior change interventions identified in Objective 2 to improve the implementation of the ARO screening tool. We will do this by hosting a virtual consensus meeting with key participants. A nominal group technique by an expert facilitator will be used at the meeting to assess and prioritize context-specific interventions. This research aligns with SHEA's high priority topic of evaluating approaches for the dissemination and implementation of healthcare-associated infection prevention methods. It will provide the necessary evidence to optimize the use of the existing electronic ARO screening tools in EMRs and to ensure implementation of future screening tools, consider and mitigate gaps in process so that ARO transmission can be minimized in hospitals. We will build an evidence base on the adherence and effectiveness of the electronic ARO screening tool using a quantitative population-based evaluation. With qualitative inquiry underpinned by behavioral change theories and frameworks, we will identify gaps in the application of evidence-based practices that are context-specific across different hospitals that use similar EMRs. We will contribute to the scientific literature on the use of behavior change theories in infection prevention and control, particularly on ARO screening. The team assembled to meet the objectives will strengthen interdisciplinary research capacity in IPNC and will facilitate behavior change to ensure application of best practices in the prevention of ARO transmission in hospitals. I'd like to thank our project leads and all the infection control professionals at Alberta Health Services that have supported this work to date. Thank you.
Hello, thank you so much for watching my video introducing my SHEA Epi Competition proposal, Association of Sociodemographic Variables and Neonatal Hospital-Onset Bacteremia in a National Cohort. My name is Erica Prochaska. I am a third-year Pediatric Infectious Diseases Fellow at Johns Hopkins University, and my primary mentor is Dr. Erin Millstone. Neonatal hospital onset bacteremia is important to study because it's highly morbid. It is associated with high mortality and an increased length of stay. Hospital onset bacteremia is an easier metric to report than central line associated bloodstream infection or CLABSI, and therefore is a planned future CDC quality metric. There are long-standing neonatal mortality disparities in the United States, highlighted here. This is 2017 data. Dark green are neonatal deaths. You can see that there are stark gaps between white, Black, American, Indian, and Alaskan Native mortality, as well between white and Native Hawaiian or other Pacific Islander, and Hispanic mortality as well. We are starting to understand the contribution of healthcare-associated infection disparities to neonatal mortality. There are higher rates of late-onset sepsis in Black and Latino Hispanic neonates as compared to white neonates, and Black and Latino Hispanic women were shown to be more likely to deliver at hospitals with higher HAI rates in the state of California. For preliminary data, I performed a sub-analysis of a previously published cohort from Dr. Millstone's research, which showed that within 3 Johns Hopkins Hospital NICUs, there was a higher crude incident rate ratio of hospital onset bacteremia between non-white to white neonates weighing greater than 1,500 grams. This showed us that we needed to explore whether this was represented in national data. The specific aim that I'm proposing is to estimate the national rate of neonatal hospital onset bacteremia or HOB and measure the independent association of sociodemographic variables on the rate of HOB after adjusting for chronologic age, birth weight, and presence of a central venous catheter. The cohort that I will be utilizing is a multi-center retrospective cohort comprised of 320 hospitals in the United States of infants admitted between July 2016 and 2021, and HOB will be defined as a blood culture positive for fungi or bacteria day 4 or greater of admission. Only infants admitted 4 more days will be included, and only 1 HOB event will be counted per patient. I will be utilizing a Poisson regression model to estimate the daily risk of HOB, adjusting for birth weight, central venous catheter presence, and postnatal age a priori, and then extending the model to look at additional variables, both clinical and sociodemographic, and then in a file model, including all sociodemographic variables with variance inflation factors. I will then conduct a subcohort analysis, pulling out from the cohort different sociodemographic groups in order to identify within sociodemographic groups where are there risk factors for hospital onset bacteremia, such as type of NICU at which a child is delivered or state in which they are delivered. Future directions for the study include identifying areas for infection prevention interventions to address found disparities, including qualitative methods to identify drivers of inequities, building upon my current interviews with NICU parents on infection prevention, understanding, and implementation. We could also estimate rates of bacteremia-associated mortality. However, we would need to use a subset of NICUs, as some NICUs included in this cohort have a high transfer out rate. I also want to take a moment to acknowledge that the drivers of health inequities are complex. This is an adaptation of the social ecological model. It shows that there's many different levels that contribute to an individual's risk of disease. For my future research, I plan to be focusing on the institutional interpersonal level, again, acknowledging that there are many drivers that need to be addressed in order to narrow the gap in health disparities in the United States. For my budget, I am proposing a salary for a research coordinator and an analyst. I'd like to thank my research team, my primary mentor, Dr. Erin Millstone, who has extensive experience mentoring trainees and junior faculty in infection prevention methods and research, Dr. Deidre Cruz, Professor of Medicine and Deputy Director of the Johns Hopkins Center for Health Equity, who's mentoring me in health equity methods, and Dr. Julia Johnson and Dr. Renee Boss, who are both neonatologists. Dr. Johnson is an expert in infection prevention and clinical epidemiology, and Dr. Boss is an expert in qualitative methods, particularly in the NICU. I would also like to thank the Millstone research team that has extensive experience in longitudinal and multiple center analyses and are mentoring me as well in how to design and carry out this study. And I'd like to thank the CDC Epicenter Collaborative and funding from the Centers for Disease Control and Prevention. And thank you very much, and I look forward to seeing you at SHEA.
Hi, my name is Alex Sundermann, and my project for the SHEA Epi Competition is entitled Enhanced Surveillance Methods for Genomic Epidemiology in Healthcare. Whole genome sequencing surveillance is an emerging method to sequence isolates regardless of the presence of an outbreak and often uncovers many outbreaks that would otherwise go undetected. When we investigate these outbreaks, we often see clues of potential routes of transmission, although lacking specific knowledge on how the pathogen was actually transmitted. Whole genome sequencing surveillance improves the detection of outbreaks, but the interventions remain unchanged. The questions here are if targeted environmental cultures can add to this and improve interventions, and also if the duration of pathogen shedding into the environment have any correlation with transmission. This study would be carried out at our hospital at UPMC Presbyterian. Currently, our hospital performs weekly real-time whole genome sequencing surveillance of major bacterial pathogens through an NIH-funded project called EDSHAT. We have sequenced over 2,000 bacterial infections in the past year and see new weekly outbreaks that we intervene upon. The objective of this project is to supplement the surveillance program with targeted environmental surveillance. Together, this would create an enhanced detection and precision of determining our transmission routes and thus enabling better IP interventions. Aim 1 of this project is to identify environmental reservoirs in the hospital and define their role in transmission. This hypothesis is that targeted environmental cultures will better identify transmission pathways. Here, targeted environmental surveillance means selecting high-touch areas within patient rooms or medical equipment which are suspected when we detect outbreaks. Our outcome would be the genetic relatedness of environmental isolates to that of patients. Aim 2 is to determine the impact of persistent pathogen carriage in infected patients on environmental contamination and transmission. Our hypothesis is that patients will persistently shed the same strain into their environment for a long time after their initial clinical infection. With this, we will measure patients that have persistent carriage who also appear to be a source of transmission to the environment and to other patients as well. To accomplish Aim 1, we will look at hospital locations or equipment that have implicated in weekly outbreaks. We will then perform targeted environmental cultures, sequence them, and compare with our patient isolates and other environmental isolates. For Aim 2, we will follow patients in Aim 1 who have shed related isolates into their environment and perform follow-up environmental cultures throughout their hospital stay and readmissions. This is a diagram depicting the methods of the aims. We have an initial cluster detection of 2 patients and will perform the targeted environmental cultures. We will look for an identical environmental isolate and continue to monitor for additional patients within the cluster and any environmental commonalities. For the patient with a matched environmental isolate, we'll perform their environmental cultures in Aim 2 by performing systematic, targeted environmental cultures over the course of their stay and readmission. In Aim 1, we will look for trends of which surfaces or equipment are most often contaminated that are related to patient isolates. We will also look for any temporal trends in environmental isolates to future patient isolates as possible sources of transmission. For Aim 2, we will look at the distribution of environmental contamination and factors that may contribute to prolonged shedding or transmission to other patients. We have some preliminary data to suggest persistent carriage of related isolates. Looking at our genomic surveillance data of patient isolates over 3 years, we see prolonged carriage of the same isolate of which had evidence transmission to other patients. The figure here depicts an example of a patient with Klebsiella pneumonia infection with related isolates 373 days apart and possibly transmitted to another patient on a shared unit 220 days after the initial isolation of the first culture. We also have preliminary data showing how surveillance data can be linked to environmental culturing. We previously described an outbreak of 6 patients with Pseudomonas aeruginosa infections, where all but one exposed to a common gastroscope. That gastroscope was subsequently culture positive for a genetically related Pseudomonas aeruginosa isolate, implicating it as a transmission route. The $20,000 requested would be dedicated to the supplies for environmental cultures and sequencing. The data generated from this project will help aid infection prevention interventions by enhancing the precision of interventions, as well as to better understand transition dynamics within the healthcare setting. This data will also be applied to a future NIH training grant. I have a stellar mentorship team here at the University of Pittsburgh with Dr. Lee Harrison, who leads our Center for Genomic Epidemiology, Dr. Graham Snyder, who directs the UPMC system-wide IP program, and Dr. Daria Van Tine, who is an expert in microbial genomics. Thank you for listening, and see everyone in Seattle this April.
All right, so as you can see, we have 3 outstanding proposals to be considered. I do want to just mention and thank those folks who submitted proposals that did not make the cut. We had a lot of good science presented, and we can only award 1 project, but thanks to all, and thanks to our reviewers, and thanks to our judges in the audience as well. So we'll start with our first presentation, and we have as our panelists querying the contestant, Dr. Julie Szymczak from the University of Utah. And our first proposal will be, as you heard the first video, improving patient safety through enhanced understanding of current practices of antimicrobial resistant organism, or ARO, screening in healthcare facilities by Dr. Jenine Leal of the University of Calgary. Jenine?
Hi, everyone. Thank you so much for having me here today. Thank you so much, Dr. Leal, for this really interesting proposal. I appreciated being given the opportunity to review it because I think that you're addressing a really critically important problem. And ultimately, what you're looking at is essentially the embedding of a tool within complex healthcare workflows to try to improve patient safety. And I think there are a number of really important strengths of your proposal. So you're addressing an important problem. You are using multiple methods. So you're using this retrospective cohort study using secondary data, qualitative study using focus groups, and a nominal group technique to try to systematically identify solutions based on what you're finding in AIMS 1 and 2, which I think is very ambitious and very systematic, and I want to congratulate you on that. I also appreciated that you integrated frameworks, socio-behavioral frameworks. You selected the theoretical domains framework and the capability, opportunity, motivation, and behavior framework as well to help you identify potential techniques to improve things. I also think a major strength of this is the study population. So you're able to get data on all admissions at 50 healthcare facilities in Alberta and Ontario that use EPIC, and I think that massive number is really powerful. In reviewing your proposal, there were a few places where I had some questions, and I think the first, it wasn't in your presentation, but I would like you to talk a little bit more about the preliminary results that you described for AIM-1, in particular, some surprising results. So that at the first 3 acute care facilities that you looked at in Alberta, there were 47 admissions that did not have the screening questionnaire completed. However, almost 17 of these still had a swab ordered, and nearly 12% of the patients that required a MRSA swab based on the questionnaire responses did not have a swab collected. And then most surprisingly, or maybe not as surprisingly from a social scientist perspective, 25% of the patients that were expected to be put on precautions were not. And so this is, kind of very fundamental to the process that you're studying, and you do say in your proposal that you are not able to get insight into why this happened in the quantitative work, but you would like to address it in the qualitative work. And I'd be curious if you could talk a little bit more about how you're thinking of investigating those very important and surprising findings in project number 2.
Great. No, thank you so much for that. So like she mentioned, in our preliminary results, we did look at only 3 facilities. And we identified that 50% of our admissions didn't have that ARO screening tool completed. And like you said, more surprisingly, 25% didn't have or weren't put on precautions as they were expected. So we're going to be exploring that a little bit further at all of our facilities in 2 ways, essentially. We're actually trying to extract more information out of our EPIC system to understand what might be contributing to those results and whether those results still hold across all of our facilities. So this was just based on 3 sites when we first started this work. We now have data on 21 sites, and we haven't yet explored this further within that data, but we will be looking at that and trying to get more out of EPIC that might be able to inform why maybe those swabs weren't ordered. Was there a history or non-history of MRSA? Was there other features or factors contributing to why patients were placed on isolation or not? So maybe they already had an isolation order, but we just weren't able to see that in our data. So we'll look at it quantitatively, and then qualitatively, we'll be asking those questions within our topic guide or focus group guide that we've developed that has been informed by the TDF, but we'll be asking those questions as to what might be the reasons why these results are being observed in the EPIC system, and potentially also asking what kinds of strategies that we can implement to address those gaps. So that, I think, is the sort of 2-pronged approach that we're trying to take and really trying to explore the quantitative or the data in the system, and then using that to inform the types of questions that we ask in our focus groups.
Great, thank you. My second question relates to one of the primary outcomes in your first project, which is fidelity. And so you're defining that as the proportion of total admissions with a submitted ARO admission screening questionnaire, what best practice actions were triggered, e.g. microbiologic screening and or an isolate, and then the timeliness of actions completed. Could you talk a little bit more about what you mean by timeliness of actions completed? What are the actions, and how are you defining timeliness?
Yeah, great. So we're defining fidelity as that adherence. So for every admission, the expectation is that this ARO screening tool is completed. And then based on the responses of those questions, certain best practice action or alerts would be triggered in the system, which would include ordering a microbiological swab or placing a patient on isolation. And according to our guidelines in our province, the expectation is that tool is completed within that 4-hour time frame or so of admission. And then subsequently, based on those responses, that those swabs or that, particularly the swabs, are done within that 24-hour period. So we want to see if, one, is the tool completed? Once it's completed and there's actions to take, when are those actions done relative to that admission time? And so we've started to explore that a little bit, and that is going to be part of that quantitative component of our study.
Excellent, thank you. My next question relates to your choice of framework, of the theoretical domains framework. So very happy that you're using a framework, but I do wonder, particularly because what you're looking at here is a technology, it's a tool that is physical in the sense that it involves humans, computers, and other kinds of things, that, you know, when my mind thinks of that, I tend to think of perhaps some other potential traditions, such as human factors engineering, so the SEEPS, the Systems Engineering Initiative for Patient Safety Framework. I use it all the time, I forget what it means. But one of the things that I think is potentially a weakness is that the theoretical domains framework, although it does have context as one of the 14 domains, that it perhaps doesn't emphasize the sort of human-tool interface as much as some other traditions, you know, in terms of these sort of socio-behavioral and contextual frameworks. And I just would like to hear a little bit more about your thoughts about why the TDF is optimal for this particular question.
Yeah, no, that's a really good point. And I think for us, based on our experience using the TDF, we felt that it was a good tool to understand that individual level behavioral characteristics that influence, or those determinants that influence that behavior in conducting the screening and looking at those different contextual factors. And you're absolutely right. We're talking about people working with a computer system and a tool. But as we start to develop even our topic guide and our focus group guides based on the TDF, we started to also ask questions more broadly about ARO screening practices in general, not just that interaction with the computer system and doing the whole process of admission screening. So our topic guide does try to grasp those different elements, and based on the experience of our team and the implementation scientists that we're working with, the recommendation was to use the TDF. However, we have a whole human factors team at our disposal as well to maybe explore those opportunities to incorporate some of that into our topic guides and focus group guides as well.
Excellent. Yeah, I would recommend that. I think it may be more fruitful. And then my final question actually does relate to the use of focus group methods. Can you tell me a little bit about why you think that's the best method to get the information that you want in this case?
Yeah, so again, that was a recommendation and also a preference for the staff that we were engaging with to have focus groups. And we felt that with focus groups, you would get more information-rich material and information from the participants, and there would allow that dialogue between the individuals, as well as feasibility to try to get individuals together from the same site or from similar areas would be probably easier. People can bounce those ideas off of each other and really get into that information-rich dialogue to understand the context and the different determinants that might be influencing this behavior. So the drive was to have these focus groups, and people were really excited about that. And so that was sort of our rationale for that, as opposed to interviews, which would require a lot more time and a lot of individualized discussions. So.
Great, thank you. I don't have any other questions.
Great, thank you.
Thanks.
None from the audience, right? No. One virtual, okay.
All right, bad moderator, don't leave your phone in the audience when you have to take the Q&A, so apologies. There is one question, and so if folks do have questions, we do have time for questions, please put them in the app chat. So the question is, for this project, talk about generalizability, since the project for the United States, seeing it's going to be done in Canadian healthcare facilities. Do you see any generalizability issues, or can you talk about that a little bit?
Yeah, absolutely. So I think when we talk about generalizability, we often apply that in the quantitative sense. And in our work, we are going to be looking at this across all of our hospitals. So right now, EPIC is transitioning through all of our 110 hospitals in Alberta, and these hospitals are spread across urban and rural areas. We have pediatric and adult facilities. And so yes, there is the potential limitation of generalizability for those sites here in the States that do not do ARO screening or do not have an EPIC system or an EMR system to be able to do that. But I think the fact that we're doing this across all of our hospitals can really contribute to that generalizability and be able to explore, from a quantitative sense, the impact of implementing a tool like this, or a clinical decision support tool in a system like this. So that is, I think, more targeted around our quantitative aim 1, the generalizability there. And I think when we're talking about aim 2 and 3, we're talking a little bit more about transferability and understanding how the context in which we are doing this work can be influenced or can influence the work in other jurisdictions. So I still think that even if we're limited in the generalizability aspect in our aim 1, the transferability of this work can still be applicable across different sites and different jurisdictions. And really, so it's going to be really important for us to draw in that context and describe that so that others can reflect and learn from what we've done, and hopefully apply that here as well. And even if it's not related to an ARO screening tool, I'm pretty sure we have other tools embedded in our EMRs that are applied on admission that this might also be generalizable to.
Great, thank you. Second question is coming through saying, how will compliance with process measures be assessed, and how reliable do you think this assessment will be? How will compliance with process measures be assessed, and how reliable do you think this assessment will be?
Compliance with process measures.
That's all I got, too.
So I think, if I'm understanding that correctly, so the process here that we're trying to evaluate is whether that ARO screening tool is completed and whether those actions are being acted on according to the responses in the tool. So we are going to be looking at compliance or adherence as we're defining it in the system by looking at all admissions and whether the tool is completed or not, and then assessing that, how reliable that is. It's a good question. I mean, we have these tools embedded. The EMR is embedded and going to be embedded in all of our systems. The tool is in that. It is a required documentation, or it's meant to be a required documentation, but as we've observed so far, it's not really happening. So really trying to understand that and understand why that it's not happening is part of all of this work. And I think in terms of just how reliable it is, we will be able to extract it out of the system. So it's a comprehensive population-based analysis. How reliable is really where that qualitative component will help us understand a little bit more, what might be happening as to why or not it's being done.
Fantastic. That's it as well.
Great. Awesome.
Thank you all. Let's give a round of applause to Dr. Leal.
Thank you so much.
And thank you, Dr. Szymczak, for the excellent round of questioning. All right, let's move to our second presentation. Our panelist will be Dr. David Weber from the University of North Carolina at Chapel Hill, and he'll be interviewing Dr. Erica Prochaska from Johns Hopkins University and her proposal, The Impact of Sociodemographic Variables on National Neonatal Hospital-Onset Bacteremia Rates. Dr. Prochaska?
Thank you so much for having me here.
So
First of all, I want to thank you for what was just an excellent presentation, and certainly understanding the impact of disparities on healthcare, particularly in the neonatal intensive care unit, very sick children, I think is quite important. Let me start off and ask you, you've talked several times about the importance of generalizability in your study, and you did mention that you have more than 300 NICUs data. Can you describe how those NICUs were chosen? Was this a random selection of NICUs? And if not, how will that affect the generalizability?
Yeah. Thank you so much for that question, Dr. Weber. It's an excellent question. So we have a cohort of academic and academic-affiliated NICUs, which Dr. Millstone, my primary mentor, has worked with in the past for prior research. And the preliminary data from those NICUs is being analyzed and is being presented as a poster presentation here. And then we also were able to get data from Mednax Pediatrics, which is a data warehouse from a group that manages and owns NICUs in the United States, including Alaska, Hawaii, and Puerto Rico. And those NICUs span from academic affiliated to community NICUs. So it is a really wide spread of different types of NICUs. In terms of the generalizability, it's a great question, and it's one that we are currently discussing the best way to make sure that we're comparing like-to-like NICUs so that we are best able to understand the data, but also best able to disseminate the data. So one way that we are going to focus on generalizability is to make sure that we're comparing NICUs that have similar transfer out rates, similar sizes, similar inborn, outborn populations, similar percent infants that are born less than 750 grams. And we will have some limitations in that we're not going to be able to track neonates, from NICU to NICU. So community-level NICUs that may be transferring out a lot of infants may appear to have a lower mortality rate or less acuity. So we will need to include that as a limitation.
So I want to turn to sort of the big picture. You're obviously controlling for many factors. The neonate things such as gestational age and chronologic age and birth weight. You're controlling for some of the factors about the presence or absence of a central line. Your key issue is to look at disparities, race and ethnicity. Let's say you do find that, for instance, African-American children do have a higher risk of bloodstream infections. What's the next step? How does that tell you what interventions we can do as healthcare professionals to reduce those disparities? What does it tell you about what's the actual driver for that disparity?
Yes, that's an incredibly important question, and it's a question that I've been reflecting on a lot as I've been designing this study. So we are collecting race and ethnicity, but that's only part of the sociodemographic factors that we're able to collect. We also have zip code data, which we can correlate to area deprivation index, parent language, insurance status from some of these hospitals. So we'll be looking at a number of different sociodemographic variables in order to understand which sociodemographic groups may be at a higher risk for preventable harm. When we're going to be looking at the national data, we may see trends that suggest that there are disparities nationally. What I'm really interested in is drilling down on, why and where. So is it particularly related to geographic region? Is it related to type of NICU? Is it related to patient language, for example? And that's really important because I'm currently doing qualitative work in the NICU, talking to parents, and qualitative work is incredibly time-consuming, and it's incredibly rewarding as well. But I think to really target that, I'm going to need to understand, where are these gaps in care potentially happening, so that I know that if I need to develop a qualitative study that looks more, for example, at neonatal intensive care units that may not be academically affiliated, or maybe it's mostly happening at quaternary care hospitals, I can focus the qualitative work that way.
Thank you. Another question. Obviously, racial groups, ethnic groups are not evenly distributed in the United States. One might expect that big inner cities would have larger numbers of those in their NICUs and smaller or even larger more areas such as the Midwest, for instance. Obviously, NICUs differ quite a bit in design. Some are pod design. Now many have moved to individual rooms. They may have different guidelines for hand hygiene, environmental cleaning, how to place central lines. Are you going to be looking at, as your analysis unit, the patient? Are you going to be looking at and controlling for any facility level disparities and use more of a cluster design where you look both at control both for the facility and for the patient?
We will be controlling for the facility, but we will not have access to data such as whether there are infection prevention bundles or nursing ratios. Those would be great data elements to have, and I wish that I had them because there has been prior research that has shown that nursing ratio, for example, greatly impacts quality of care in the neonatal intensive care unit. But we will be controlling for NICU level of care, the amount of infants that are born extremely premature and extremely low birth weight.
Thank you. One last question. In epidemiology, we talk about the ecologic or the epidemiologic fallacy, where you're looking at analyzing patient data such as socioeconomic class, education, based on, as you are, zip codes, which is a larger area, which may or may not correlate with individual patients. What, if anything, will you do to control for that?
Yeah. So that's also an excellent question, and it's one that I have been thinking about a lot. The ideal would be able to get actual census tract data, right, which we know is better. Because of the way that we are sharing data with these institutions, we don't have that available. So in terms of, how might I be able to control for that, that's part of the reason that I wanted to collect as many sociodemographic data elements as possible. I think if there is evidence of a disparity, then the next step would also be to develop a cohort where I have more data that can be more finely tuned to focus in on the specific areas where there are potential gaps in care. So, for example, if we find out that it seems to be very geographically related, we may try to get data where we are able to more finely pinpoint, where families are living, the distance to the NICU, look more at census tract level data. So I agree with you that it is a limitation of the specific study, and as you mentioned, the zip code areas are quite large, but I think that this is a really important place to start so that we can start asking those tough questions about what do we need to do next.
Thank you for an excellent proposal, and I think there may be some questions from the audience.
Yeah, we have some audience questions. So the first question is, for your project, variables like race are often incomplete or wrong, and I'm assuming they mean within the patient EHR. Any strategies to bolster validity and or account for missing data for those variables?
Yeah, so that's a really excellent question, and that's a question that I've also been asking myself and my research team a lot, and Dr. Cruz, my health equity research mentor, has had to talk me down a lot about that as I've been sort of panicked about the fact that we are finding out more and more that EHR data may not actually represent race. I mean, part of it is using more hospitals, a larger data is partially there to account for that. And then, when I had been discussing with Dr. Cruz the best way to address the fact that I don't have address level data, I don't have self-reported, race, ethnic, language data. She had actually suggested doing the sub-cohort analysis where we're able to pull out language group, for example, or ADI level, or race, ethnicity, and then really try to figure out, for example, comparing infants that are born to women who speak a language other than English versus English, where are their risk factors for bacteremia? Who's having infants that have bacteremia versus don't? Is it, one area of the country? Is it one type of NICU? Is it, one birth weight of infant? And so that's the best way that I've tried to control for that limitation, but it's a big problem nationally, and a lot of healthcare systems are working to improve the EHR data, and I think research like this is important for continuing to push forward why we need that data to be improved.
Yeah, thank you. Next set of questions are around some of the data, the question of collecting data. So it's from the same querier, and so I'm going to bundle these two together. But for your presentation, will any maternal risk factors and prenatal variables be collected and analyzed, and also will you get staffing data for the NICUs?
So I heard maternal data and
prenatal variables, as well as staffing data for the NICU.
Yeah. So unfortunately, I don't have maternal data from all of the sites. It is a possible variable to collect from some of the sites, but not all. And I don't have staffing data, but that is something that could potentially be collected again as we do further analyses. So I think the prenatal component is extremely important to consider. And certainly it is going to contribute to neonatal outcomes. But we are looking at hospital-onset bacteremia because we're looking at bacteremia outside of the first 3 days of life or of admission. So, theoretically, there's going to be more of an influence of things that happen in the NICU on this particular risk factor. But of course, the maternal health and maternal access to care is extremely intertwined with neonatal health as well.
Yeah, thank you. And last question is, why use admission day 4 to define your hospital-acquired infection? CDC, NHS, and HAI timeframe begins on day 3.
Yeah, so excellent question as well. That's because we didn't want to overlap with early onset sepsis in neonates, which is getting at what I said before, where we're trying to focus on where there may be the most preventable harm.
Outstanding. Thank you.
All right, thank you so much.
Thank you, Dr. Prochaska and Dr. Weber, for some excellent questions, an excellent presentation yet again. So our final pairing, our panelist querying the submitter, the applicant, is Dr. Monica Mahoney from Beth Israel Deaconess Medical Center. And she will query Dr. Alexander Sundermann from the University of Pittsburgh on his presentation, Enhanced Surveillance Methods for Genomic Epidemiology in Healthcare. Alex?
Good morning. Thank you, judges, for your questions. And Dr. Mahoney, thank you.
Thank you for your wonderful presentation. I think it's very exciting to bring something that we oftentimes think of being only in the research lab to the forefront of clinical practice, and there's lots of implications for it. And I think it's a perfect marriage of infection prevention, epidemiology, patient care, and potential outcomes. So very exciting. The first question in your proposal and then in the summary that you presented, something that was missing was your statistical analysis. So can you spend a couple of minutes just going over exactly what kind of analyses you plan to do?
Right. So we're going to be looking essentially at rates of transmission. So the number of incidences that we actually sequence and we see transmission, how often to those subsequently contaminate the environment and have onward transmission, we're able to find and quantify that amount of transmission. One of the difficulties is, trying to effectively predict how many we're going to have through sample size calculations and like that. And we do have long lengths of stay where we can actually get up to those 30-day readmissions and even longer than that within our hospital. Looking at some of our previous data where we had over about 300 patients, 8% of those patients had attributable 30-day readmissions just to that. So we have even more than those that are staying longer for just other different kinds of readmissions. So we want to essentially stratify by the length of duration of that these patients are in the hospital and the number of times that we're seeing environmental contamination and forward transmission, and summarizing that data in an ecological manner.
Great, thank you. You touched upon length of stay, which was the next question that I had. In your presentation, you mentioned that sampling will be done on days 3, 7, 14, and 30 after the initial culturing encounter. What are the average length of stays for your patients, and how will you handle patients that have a shorter length of stay? How will you get that day 14, day 30?
Right, that's a really good question. That one thing that Dr. Snyder and I have gone back and forth on. So we have a very acute ill population. So we do see patients with very long duration lengths of stay. But in terms of our patient population that we're looking at, I don't have the approximate average duration of length of stay, but looking at in some of our previous data, in the prior question that I just mentioned, we have plenty of patients that are repeat coming into our hospital as well for attributable readmissions. And then looking at some of our persistent carriage transmission, we have patients that stay with us for years over time and come back into our hospital. So for each of those times that they come back, if they're due essentially for a 30-day query within their environment, we have a ways to flag those patients, alert, and set us up so that we know to go visit those patients and include them in there. And I think it's important to stratify within those patient populations is, we can't compare the patients that are here for just 2 days to the patients that are here for the entire year within a study time frame. So I think we have to set the different tiers of stratification so that we appropriately evaluate which groups do we compare to and to have that statistical summary.
Mm-hmm. Great. So you, in your flow chart, you showed a visual representation of when a trigger occurs, how the process would go. What is a trigger? How will you identify when you start the swabbing and the sequencing?
Right, so we sequence every week. We gather clinical isolates twice a week from our clinical lab building. The entire process from when the bedside clinician actually collects that culture to the time frame where we've done the sequencing, we've analyzed it, and we've investigated it for possible transmission. The median time we're seeing is about 14 days. So from culture time frame to whenever we're actually potentially intervening is 14 days. After that initial clinical culture. So at that time frame when we suspect transmission on a certain route, which is about 75% of the time we see some type of epidemiological commonality, that's when myself would go down to whatever route that may be. Is it a unit? Is it a procedure? Is it a different area in the hospital? And perform that environmental culturing so that we can get as close as possible to whenever we actually see transmission occurring into the hospital. With the same approximate turnaround time, about 14 more days, we can have genomic results from our patients' clinical infections in about a single month to see what they're shedding into the environment and other possible forward contamination.
Mm-hmm. So this is obviously not occurring in a vacuum. You have your infection preventionists working at the same time that an outbreak is identified. Assume that there is enhanced cleaning occurring when this happens. How will that impact your results or your study or the data that you're collecting?
Yes, it's definitely a limitation. So whenever we find these clusters, we immediately notify our infection prevention department, and of course, ethically, we have to intervene. And that's mainly the purpose of this proposal, is because our intervention often when we suspect unit transmission is the kitchen sink. We say do better hand hygiene, do better cleaning, do education on better interventions. So the purpose here is to say, well, we see it's often probably contaminated medical equipment. We can have interventions on enhanced cleaning on this type of equipment. Or even if we don't see any environmental contamination, that it could actually be healthcare worker hands and they're not actually performing proper hand hygiene. So this will actually guide us to a better intervention, but there is that limitation of, yes, we are doing enhanced cleaning whenever we are finding these, so that is a limitation that we are going to face, that perhaps the enhanced cleaning is prohibiting us from finding and recovering the environmental culture. But I have a very firm belief from what we've had in the past and doing environmental cultures that we will still be able to actually recover these in the environment.
Okay. And then the final question is, you mentioned that you will be doing targeted sampling of the environmental surfaces. How did you decide what will be targeted, what will be sampled?
So I think it's going to be very transmission dependent. So whenever myself and the IP team do the chart review, we look for commonalities, and within a unit, that's going to be the general high-touch surfaces within a patient's environment. But we also want to look at the reusable medical equipment that it has the ability to move around to different patients as well. That's going to be most likely implicating it within the transmission. We see suspected outbreaks within operating rooms, within certain types of procedures, which have very unique equipment that's specific to those, such as maybe the water in the room or the equipment that's used specifically for that procedure. In that case, it's going to be targeted specifically for those things that we see in the room. So I think it's going to be a case-by-case basis, but generally those high-touch surfaces that we see most often implicated in transmission and info through hands.
Great, thank you. That's all I had.
Thank you.
Thank you. All right, we've got some questions in the chat. I think one that just came in, I think you just answered, but will the environmental assessment include shared patient equipment as a target, and how will you determine surfaces? I think you did say that shared equipment would be in that.
Right, and even too with sampling methods as well. Dr. Curtis Dauncey gave a great talk yesterday about sampling methods. The sampling method would be different for each type of surface that we see, whether it's hard or different types of intricacies or water.
There's a couple questions kind of in the same general theme, but I'll read them separately a little bit, but the answers may be similar. So for AIM-1, can you expand on the interpretation of the environmental culture data? We would assume the environment will be routinely contaminated by patient flora. If the same organism via whole genome sequencing is found in other patients, why invoke transmission from environment instead of a healthcare personnel or other source? So kind of talking about that dynamics of is the environment where the transmission happens, or is it just a happenstance contamination? And kind of talk a little bit more about that directionality, because other questions are around directionality of transmission determined, such as patient environment, patient from staff member, et cetera.
Yeah, directionality is extremely important. The question comes up, did the patient contaminate the environment? And then for the future patients as well, is that causality and actually causing the future infections? And it's very difficult to determine, and I think whenever we look at our data when we recover, we look at future patients within our outbreaks and did they have commonalities with the equipment that we know were culture positive, genetically related, and then subsequently later positive with the same genomically related isolate. And I think that's our best proof at showing directionality in the transmission change. We do have some preliminary data as well with the manuscript that's under review of the pseudo outbreak within our autopsy suite, where we found contaminated autopsy blood cultures in a bunch of our patients. And this is a great scenario to show that directionality. We saw this transmission happening. We went and watched, and we made a hypothesis that it was coming from the water. We cultured the water source, not the drain, and the source had a matching isolate to that of patients, and we had future patients after that culture that matched that sink isolate, meaning that we had directionality because the source was actually causing the contamination and forward. And I think examples like those are what we're going to be looking for, where we have the best chance to show directionality with temporality within our cases.
Thank you. Question on, will there be any tracking of environmental cleaning on the units or within specific rooms as part of the analysis?
Environmental
yeah, the tracking of the cleanliness and the process of cleaning the units in the rooms as part of your analysis or planning?
It is not planned as part of our analysis. Our practice is pretty standard with the current guidelines. We're not planning on changing them as well. Like I mentioned before, we do an additional cleaning whenever we suspect transmission. So that's just going to be a limitation that we have in our analysis.
Next question is, what will patient characteristics be looked at? Will that help understand characteristics of prolonged shudders and duration of isolation?
Is it caregivers or patient characteristics?
Patient characteristics.
Yeah, so we know that's definitely a risk factor in type of prolonged shedding. Those who are immunosuppressed transplant patients, critical patients, are more likely to shed within their environment. It's not an official planned analysis within this proposal, but I think it's definitely a key indicator to look at future studies to say what types of indicators often translate to persistent environmental shedding of the same strain.
Yeah, there's a lot of questions coming in.
Yeah.
Question on the actual environmental cultures. Will an environmental microbiology lab be conducting those cultures?
So myself will be actually doing the environmental cultures themselves, and I have a lengthy experience of performing thousands of environmental cultures through different investigations, and I'll be doing the process. We have resources to multitoph to identify the same species, and then the sequencing is performed in-house within our own lab through a bioinformatics pipeline that we've established.
Thank you. Next question is, if there's a 14-day lag in identifying a transmission event, won't most of these patients have already been discharged? How many patients clusters are you expecting for your sample size?
Right, so that's one of those limitations, again, of looking at repeat patients, patients who have prolonged stays as well. It's just something that we're going to have to observe and manage as we go through to see how long these patients are staying in.
We're getting towards the end. You're doing
okay.
You're doing great. Do you plan to culture hands of healthcare workers? Should that be considered?
I think it should be considered. Currently, we are not because of the enrollment process of having a different type of trial. So I think in a future study, it's something to include. Some of our collaborators at UPMC have cultured hands of healthcare personnel for CRE, and I think that's a really important thing to consider, but not within our specific proposal.
Thank you. And there's a related, do you plan to culture patient hands as well? That's a
right,
similar answer.
Yeah.
Considering the time it takes to get whole genome sequencing results back, any ways to institute preventive measures rapidly in the process?
So we're at 14 days, which I think is pretty quick, and most of our time could be cut down on just general operations. We found that whenever our IP team actually suspects an outbreak, the majority of the time it's not an actual outbreak. The isolates are often unrelated. So I think proactive measures in our sense aren't as effective as just waiting those 2 weeks to confirm the presence of the outbreak and having a better targeted intervention.
Yeah. Last one. You're doing great. Can you elaborate a little further on what you're looking at regarding colony counts and risk of transmission? Different pathogens may have a different amount of exposure, both temporal and organism burden.
Yeah, so with colony counts, that's a good point, and looking at environmental recovery of how much can we actually recover from the environment. And of course, there's also that limitation of, there probably are multiple strains within a single sample. How do you actually appropriately pick the strain and extract that out? And that's something that we've had issues tackling in the past. But I think what we're looking for is just the presence or absence of that related strain in the environment as an indicator of possible transmission, not necessarily the amount or the quantity that exists in that environment. As long as we're able to recover it, we're able to show that it's there and has the potential to cause transmission.
Thank you. That is it.
Thank you. Thank you, Dr. Mahoney. Thank you.
So thank you, Dr. Sundermann, and thank you, Dr. Mahoney, for the questions as well. So that concludes our presentations. I do want to remind the secret judges that are out amongst you that you have till 11 a.m. to turn in your decisions. The winner will be announced later on today, I believe. But thanks to all three of our presenters. These are three outstanding research proposals. It's very difficult to pick just one, I imagine, and really exciting to see kind of science and the thought process. And so really encourage folks, if this stimulated some ideas, to think next year for the Epi Project and think of some projects you may be up on the stage to win some money to do your project next year. So thank you all, and hope you're enjoying your meeting. Thank you.